and welcome to yet another episode of Maharashtra IIP Journal Journey with Raigad IIP. Our team present recent research and the articles which can be used in practice, which will improve our patient care. This month's article address the basic issues of environmental pollution, which is crucial to ensure a healthier future generation of our country, India. 37% of our rural children are stunted. Why? The second article is about prematurity. The iron stores are transferred from mother to fetus in late pregnancy. And so 80% of 32 weekers are anemic. Let's know about it from our experts today. Now, may I invite Raigad IIP editor and Secretary AHA, Dr. Neha Singh, for a formal welcome. Over to Dr. Neha.
Thank you, Chitra ma'am. Good evening to all the respected dignitaries, my seniors and colleagues. I, Dr. Neha Singh, welcome you all on behalf of MahaIP and IP Raigad. I welcome you on the 1st of September as Journal Journey of today. I welcome MahaIP President Dr. Sanjay Pakmore sir, Dr. Amol Pawar sir as our Secretary General, State Convener Dr. Sanjay Deshmukh sir, MahaIP President 2022 Dr. Hemant Gangulia sir, Dr. Minash Sheikh sir, Raigad IP President Dr. Vikas More, Dr. Neeman Mohanty sir, respected Dr. Mahesh Mohite sir, Dr. Jay Bhandarkar sir, Chitra ma'am, and all the respected executive board members from Central IP, Maha IP, IIP Raigad, and as well as other branches. I also welcome our esteemed experts of today, Dr. Jagdish Dekne sir and Dr. Vaidehi Dhande, and our presenters of today, Dr. Apeksha Gupta and Dr. Tasneem Bashir. Now I invite MahaIP President Dr. Sanjay Pakmore sir to please give his blessings. Over to you, sir.
Namaskar. Welcome to the MahaIP platform and this very unique activity of MahaIP since last 4 years, Journal Journey. It is a very different activity from the other academic activities of MahaIP. Something new, something means going to the papers. I mean, it really invites you again, means you find it, you are again going to the college and you're a PG. And so it gives a very different experience. So once again, I thank IIP Raigad especially for taking the great efforts in continuing this particular program. And every president means is continuing this program because the quality of the program and the efforts they are taking, they are really praiseworthy. And Madam Chitra and Neha, they are doing the wonderful job of every month. I mean, lot many means before the program also there are retakes and then everything. And that is really amazing. So once again, thank you Raigad branch for this particular program. And I welcome today's expert, Dr. Jagdish Dekne sir, and Dhande madam from Wadia Medical College as experts, and today's presenters, Dr. Apeksha Gupta and Tasneem Bashir. So I hope today's experts and presenters will give us a wonderful insight into these two particular papers, and out of which the one topic is with the environment. That is again, we just now at the West Zone Pedicon at Surendra Nagar, we have seen the conference on the environment. It was a wonderful conference because I do attended some sessions of that, and I find it something new, something learning about the global warming and so all these things are today means through this particular paper we are discussing. And I welcome for this platform Dr. Minash Sheikh sir as a convener for scientific program. Sir is doing again doing a wonderful job for the last 8 months, and really means we are here a pure academic is discussed, when nothing is, we are not doing any program out of vested interest or out of politics. We are doing all the things as per the academics and as per the merits of the speakers. So nobody is asked to means interfere in our academic program. And hence onwards also, in the last 4 months, even though there might be the election fever, we may not allow any such things in this MahaIP platform. MahaIP will run on his own style with how it ran in the last 8 months. In the next 4 months also, MahaIP will take all the good programs, what we are doing, and we'll continue those particular programs till the end of this year. So, and I again welcome Dr. Gangulia sir, Dr. Jay sir, and Chitra madam, Neha, and all the MahaIPians attendees who have joined to that, and especially the Srinivasan sir, who is every time is well in time is connected with this particular program. So welcome, Dr. Srinivasan sir, and all the MahaIP attendees, and I give the best of luck
Thank
to
you,
the
thank you.
presenters. Thank you. Over to you, Neha.
Thank you so much, sir, for your encouraging words and blessings. Yes, we welcome Dr. Srinivasan, sir, and the other dignitaries. Now I request Dr. Amol Pawar, sir, to give his blessings. Over to you, sir.
Thank you, Neha. It has been a wonderful initiative by Raigad IIP. This has been started by Dr. Jay Bhandarkar sir, Gangulia sir, and our Niven Monti sir, and well supported by Dr. Neha and Dr. Chitra ma'am. And after 6 months of this starting this program, it was clubbed with MahaIP, and now since 3.5 years, it is with MahaIP, and presenters from different parts of state as well as country, they are involved in presenting these various topics on various systems, be it neonatology or respiratory or hepatology and all other specialties. And these topics are very well chosen by our Nimen Monti sir, Professor Emeritus of MGM Medical College, Navi Mumbai. And this activity is well supported by all Raigad IIPians. President Dr. Vikas More sir, since last 2.5 years, he has been president and he is supporting this initiative. Today's expert, Dr. Jagdish Dekne sir, Vaidehi ma'am, both are stalwarts in their own fields. Jagdish sir, खांसी की बात जब आती है तब सर का ही नाम पहले आता है, because about cough, he is the person who tells all the general pediatricians all the tricky things about cough and how to manage it in monsoon season or any other season. And also I welcome Dr. Srinivasan sir, Dr. Sagar Wag sir is there, Dr. Singarul sir is there, Dr. Ashwini Agarwal sir is also there, and all the other dignitaries. And this is also this program is also well supported by Dr. Ajay Kohli, Secretary of Raigad IIP branch, and all other senior members like Dabadkar sir, Mahesh Mohite sir, and everyone. So I wish all the best to both the presenters, Dr. Apeksha and Dr. Tasnim from Wadia Children Hospital and Miraj Government Medical College respectively. So wish you all the best and wish you all happy learning. Thank you. Over to you, Neha.
Thank you so much, sir. Now I request Raigad IIP President Dr. Vikas More, sir, to give his blessings. Over to you, sir.
Thank you so much, Neha. I'm so proud to be representing my branch, IIP Raigad branch, which consistently associated with my IIP and doing this wonderful job of presenting the journal journey since so many years with a leadership like Chitra Kulkarni madam and Niman Mohanty sir. I can use this word proud because I feel really proud from my heart. And it is consistently being supported by so many presidents and now current presidents, Sanjay Pakmode sir and my dear friend Amol Pawar. They are so much with us for any initiative, and especially our the seniors like Mahesh Mohite sir and Jai Bhandarkar sir, Gangulia sir. They are always behind us to do this activity. Neha is a very able colleague who handles all challenges that we face, and I'm so happy that so many stalwarts like Sringar Veli sir, Srinivasan sir, everybody has joined this program. And my favorite Jagdish Dekne sir is the expert today. That is a cherry on a cake. And Vaidhi madam as an expert. And I give best of luck to Dr. Apeksha and Dr. Tasim. So Tasneem for their presentation. And I encourage everyone for an upcoming conference, LLB Plus, that we are going to organize in a plush venue of you at Bandra on coming 13 and 14 September. So I encourage everyone to register for this conference. It will be academic fees. You will not regret for registration. You will definitely enjoy the academic fees. So with this fulfilled heart, over to you, Neha.
Thank you so much, sir. Now I request Mahesh Mohite, sir, to please give his blessings and introduce our guest experts of today. Over to you, sir.
Thank you, Neha. Once again, you have been really doing wonderful job. I'm really proud of our own home branch, Raigad IIP, for taking it forward. And those who don't know, this is a 5 years completed program, something amazing on the IIP platform. And on a journal, somebody may not even wonder or kind of imagine the program of a journal can go on for 5 years. And somebody said, seniors like Dr. Srinivasan, when he has been attending this, it clearly gives a benchmark of academics to the program. So, so I can proudly say when Dr. Srinivasan there, you can say year on year he has been attending. Dr. Nimai Mohanty I'm not seeing today, but he's really a backbone of this whole program. So thank you very much. And today, I think we have Dr. Dekade sir here as a senior consultant. He is again a dear friend of mine as well as the Raigad IIP. For every Raigad IIP program, he has been there. And he is a postgraduate teacher of DCH. He's from Pune. He's a director, Unique Hospital for Children in Chinswad, Pune. The chief pediatrician, Karthik Group of Hospitals for Children, PCMC Pune, practicing pediatrician the last 40 years. We all know him, as Amol said just now, as a person, a cup man, you can say. So like Iron Man is a cup man. Whenever there is a topic dedicated to cup or something, then Dr. Dekade sir is always there, either as an expert or as a panelist or whatever. He was a past position, he was the past president of Pune branch of IIP. He was a Maharashtra state branch president, and then he was a lecturer in pediatric in BJ Medical College in 81-82. So welcome, sir. And that's about first session. Do I introduce the other faculty at the same time, or we'll take it during the second
Yes.
case?
Yes.
Yeah.
Now
Sir, you
only,
can
Doctor.
introduce
now
both
only.
the experts.
Oh, great. Then Dr. Vaidehi Dhande, again, I know her for last more than 10 years. He's from Wadia, where I visit as an honorary for last almost 10 years or more than that. Another brilliant pediatrician from Wadia. And she is basically MBBS from GMC Nagpur. She is MD from GS Medical Mumbai, and then fellowship in neonatology at Wadia Children's. Later on became associate professor at BJ Wadia. And then she's a senior consultant division of neonatology at BJ Wadia again. Her special interests are in neonatal resuscitation, breastfeeding and lactation and high risk follow-ups. And she is currently secretary of Mumbai Breastfeeding Promotion Committee. She's instructors for basic and advanced NRP program. There are several publications to her credit. She is presently attached to Care for You Clinic in Prabhadevi, BJ Wadia Hospital in Children, and SRCC Hospital at Mahalakshmi. She is affiliated as a lifetime member of IIP, executive committee member of NFM, NNF, MBPC. So a lot of things are there. Her biodata is huge, but this is a summary of it. Welcome, Dr. Vandehi. Thank you very much for being here as an expert. It's over to Dr. Neha and then subsequently the presenter. Thank you very much.
Thank you so much, sir. Now I request Dr. Jay Bhandarkar, sir, to kindly introduce our presenters of today.
Thank you, Neha. Our today's first presentation is Dr. Apeksha Gupta. MBS done from the Jawaharlal Nehru Medical KL University, Belgaum, and MD Pediatrics from Kasturba Medical College, Bangalore, Manipal University, highest mark in theory exam, and then senior residence at Deen Dayal Upadhyay Hospital, New Delhi, and ongoing IIP fellowship in neonatology from Wadia Children's. She has done a research paper on the ability to mother to conduct essential newborn care to moderate and late preterm neonates, enrolled in the neonatal intensive unit. So welcome, Dr. Apeksha, all the best. The second presenter is Dr. Tasneem Bashir, young budding pediatrician, final year resident from Government Medical College, Miraj, from my Sasurwadi. Yes. Thank you, Neha. Again, what all Ganpati Appa, sub to you, all to you.
Thank you so much, sir. Now
We acknowledge the presence of Dr. Deepa Firke ma'am also. For the first time, she has attended Journal Journey. Welcome, ma'am. Over to Neha.
Yes. Now I request Dr. Apeksha Gupta to please share her presentation. She will be presenting on milking of the cut cord during stabilization of infants born very premature.
Good evening, everybody. So today's journal topic is milking of the cut cord during stabilization of infants born very premature, a randomized controlled trial. And the session will be moderated by Dr. Vedahi Dande.
Apeksha, will you be able to switch on your video?
Okay, ma'am.
Yeah, thank you. You can continue.
Yeah. So this article is from the Journal of Pediatrics, volume 278 in the March 2025 edition. The authors are Walid L. Nagar, Souvik Mitra et al. And this is a parallel group randomized control trial, which is conducted at the NIC of Halifax Hospital, Canada. So deferred cord clamping or delayed cord clamping is a standard care as told by the WHO, wherein around 30 to 60 seconds are taken for an obstetrician to clamp the cord. So the advantages of deferred cord clamping are that it increases the hematocrit levels, it reduces the need for blood transfusions subsequently, and it decreases the mortality in infants born very preterm. Some disadvantages are that it is contraindicated in interrupted placental circulation like placenta previa and abruptio placenta. And it calls for delayed resuscitation in some premature neonates. And it cannot be done in neonates which are non-vigorous at birth. So there's this concept called cut umbilical cord milking, where after the normal NRP protocol is taken for the first 30 seconds, the umbilical cord is milked for the next 30 seconds. So the advantages of that are that it allows for simultaneous blood transfusion with the establishment of breathing and pulmonary circulation. And it is known to improve hemoglobin and iron stores at the end of 6 weeks. The disadvantages are that if done at a very fast pace, it might lead to hemodynamic instability and also lead to insufficient volumes of placental transfusion to the premature neonate. So what is the need for the study? So the delayed cord clamping is accepted as the standardized method of cord clamping post-birth in neonatal preterm infants, which is usually being practiced. But it cannot be done in some conditions, as I have told before, like placental circulation being interrupted. So in such cases, we can use the cut umbilical cord clamping, as it is hypothesized to be easy, safe, and acceptable practice by the obstetricians and neonatologists without causing any adverse effects. And also it has good outcomes at the end of 6 weeks, like hemoglobin concentrations. So the objective of this study was to investigate the feasibility of the cut umbilical cord milking compared with the standard practice of the deferred cord clamping at birth. Feasibility was assessed based on the recruitment percentage, the intervention compliance, and the study completion in both the groups. So as I've mentioned, the study was held at IWK Health Center, Halifax. It was registered and informed consents were obtained from the mothers. So this study included all the eligible women who had preterm labor between 23 weeks to 32 weeks of gestation, and all the mothers with interrupted placental circulation having monochorionic twins, higher order multiple pregnancies, fetus with major congenital anomalies and chromosomal anomalies, and fetus having diagnosed fetal anemia in utero were excluded from the study. So total number of 203 mothers were assessed for eligibility, out of which 93 mothers were eligible and consenting. And they were allocated into 2 groups. So total 46 mothers were enrolled and 50 infants were enrolled, which were allocated to the intervention group, that is the cut umbilical cord milking, and the normal deferred cord clamping group, which equal number being 25 each. And all the infants underwent bedside echocardiography at 12 to 24 hours of life to check for hemodynamic stability. And they also underwent neurosonogram at 6, 12, 24 hours of life for checking for interventricular hemorrhage. So what was exactly done was that in the deferred cord clamping, that is the control group, initially for the first 30 seconds, as per the NRP, the infants were resuscitated. They were provided warmth. They were wrapped in a plastic wrap, and they were also provided with suction. The infants who were non-vigorous were also provided positive pressure ventilation. And then at the end of 60 seconds, the cord was cut and clamped. Whereas in the cut umbilical cord milking group, the standard NRP practice resuscitation was done for the first 30 seconds as advised, post which the cord was clamped about 5 centimeters from the introitus in the normal vaginal deliveries, and from the abdominal incision in the cesarean sections. And the infant was handed over to the neonatologist, where the neonatologist milked the cord once towards the infant for 10 seconds, after which the cord was cut and clamped near the umbilical stump. So what were the outcomes? The primary outcome of the study was based on the percentage recruitment and the intervention compliance. And the secondary outcome was studied based on the intervention safety. So these were the proportions of the adverse events. So some adverse events which they studied were hyperbilirubinemia, hyperkalemia, and interventricular hemorrhages. The other outcomes were noted at the end of 6 weeks, which were increased in ferritin levels and the hemoglobin concentration in such preterm neonates. So the study was done based on, the analysis was based on the intention to treat, and all the analysis was done using the R software, where the continuous variables were studied through the Wilcoxon rank sum test, and the categorical variables were studied through Pearson chi-square test and Fisher's exact test. So coming to the results, so the baseline characteristics of both the maternal and the infant were almost same. So only one thing which was characteristic was that the time taken to establish the first breath in less than 30 seconds was found to be less in cut umbilical cord milking group than the differential cord clamping group. Other than that, there was no change in the maternal characteristics in both the groups. So the outcome at birth seen in both the groups did not show us any significant positive pressure ventilation requirement or chest compression or intubation requirement at birth in our intervention group, which is the controlled cut umbilical cord milking group. And the mean time taken to clamp the cord was 33 seconds in the umbilical cord group, whereas 39 seconds in the delayed cord clamping group. For the cut umbilical cord milking group, the median interquartile range for cord milking was 62 seconds, and the length of the milk cut cord was approximately mean of 20 centimeters. So the outcomes. So post the study, as we can see the outcomes in both the groups. So there are 4 major risk factors which we studied here, which is the hyperkalemia, interventricular hemorrhages, necrotizing enterocolitis, and hyperbilirubinemia. So as we can see that in both the groups, the statistics is almost the same. So there is no increased adverse events post the cut umbilical cord group as compared to the differential cord clamping group. And as we can see in the last line, the mortality rates are also the same between both the groups. So hence, they concluded that the cut umbilical cord milking does not pose any significant threat or adverse effect to the neonate as compared to our conventional deferred cord clamping group. So the parental consenting rate was 70%, and all the infants completed the study except one in the cut umbilical cord milking group, which was due to the short length of the cord which was cut. So the infant could not complete it. And the compliance was noted to be more in the cut umbilical cord group, which was 96% as compared to the 80% in the DCC group. And even the non-vigorous infants at birth were found to be more in the DCC group, 80% group. And in such infants, we can, as we hypothesized in the beginning, in such infants which are non-vigorous or where DCC is not possible, we can do cut umbilical cord milking with no adverse effects. So the other studies done were showing a non-compliance rate of 27% for the DCC group at the end of 60 seconds. And also they showed the increased hemoglobin and ferritin concentrations with no adverse effects at the end of 6 weeks in the intervention group. But those studies were done at a higher gestation age of more than 30 weeks, whereas we have enrolled, this study has enrolled extreme preterms from 23 weeks onwards. Then there were some other physiological concerns, which were, if it was done at a fast pace, as I have mentioned, there will be a lot of volume of blood going to the infant, which can cause hemodynamic instability in such preterm infants. So coming to the strengths of this study are that it is easily applicable, and it is superior to the intermittent umbilical cord clamping, and it is also superior where differential cord clamping cannot be done. It avoids the physiological concerns as they've done it for 10 seconds once at a slow pace, and it also allows for brief differential cord clamping for first 30 seconds while providing the initial resuscitation steps to the infant. The limitations of this study were that it did not address the long-term safety or benefits of the intervention, and it was limited by the tertiary care settings and the sample studied. The antenatal consenting in this study was convenient for the parents, and it still requires some amount of training for both the obstetric and neonatal teams. So what we already knew was that at the end of 30 to 60 seconds after birth, we preferred the differential cord clamping as the standard of care for preterms. But what this study adds is that the cut umbilical cord clamping was found to be feasible and not increased with any adverse effects for the preterm neonates. It also added a benefit of increased hemoglobin concentration at the end of 6 weeks. The scope for further study was that the clinical benefits in human infants born preterm are not very well demonstrated, and further there is a need of study in this subject. Thank you.
Thank you, Dr. Apeksha. You have presented very nicely. Now I request Dr. Vaidehi ma'am to give her expertise comments. Over to you, ma'am.
Yeah. Thank you very much. Just a minute. Am I audible?
Yes, ma'am, you are audible. Just, I think so two connections have been put up.
Is it okay now?
Yes,
Yeah.
please continue.
Yeah. So, as we all know, and as per the neonatal resuscitation protocol, delayed cord clamping is the standard of care. And the cord can be clamped anywhere from 30 to 60 seconds. The cord at 60 seconds to placental transfusion, because it has been found that by a delayed cord clamping, there is an extra volume of blood which is transferred to the fetus, which increases the blood volume, and it not only leads to lesser risk of anemia and higher hemoglobin, but the main intention is to increase the blood volume and to ensure good hemodynamic stability, and it is advisable that the first breath is taken before the cord is clamped, so the blood pressure also is better after delayed cord clamping. However, like Dr. Apeksha said, it is not always possible because as per the NRP teaching, around 10% of the babies are not vigorous at birth, and many studies have shown that in spite of lot of training, still around 20 to 30% of the babies do not get the benefit of delayed cord clamping. There have been studies of intact umbilical cord clamping as well. That is, before the placenta is separated from the fetus, the umbilical cord is milked so that whatever blood is there reserved in the placenta is milked into the fetus to increase the fetal blood volume. But that needs a lot of training, and it may not be very well acceptable, especially in non-vigorous babies as well as in preterm babies, because many a times more the preterm baby, more is the need for resuscitation. So it becomes too much to do in a very short period of time. So cut umbilical cord clamping can be an alternative to give a benefit of placental transfusion to such preterm babies where delayed cord clamping or intact cord milking cannot be done. So ideally, the procedure is that the umbilical cord is cut, a long length of umbilical cord is cut immediately after birth, and then very slowly it is milked from the mother's end to the fetus, and it is done at the rate of around 10 centimeters per second, so that the complete milking can be over within around 10 to 15 seconds, and all the blood which is there in the placenta, in the umbilical cord, enters into the fetal circulation. So there have been some studies in the past which have shown that like the PREMODE study or PREMODE 2 study, in which there was an increased risk of intraventricular hemorrhage, because of which this study was terminated. It was found that babies between 23 to 28 weeks of gestation, those babies, the risk of intraventricular hemorrhage was very high, but from 28 to 32 weeks of gestation, cut umbilical cord milking and intact umbilical cord milking both were found to be beneficial if delayed cord clamping could not be done. So wherever delayed cord clamping is not possible, it is better to try and do at least cut umbilical cord clamping, because it is very easy to do. It doesn't need a lot of training. It just needs a little bit of counseling. So it is a way to go forward. We definitely need more studies in this aspect, but it would be a very good intervention to do for better stabilization of preterm babies who are born, which are born. Yeah, that is my take on this.
Thank you very much, Dr. Vaidehi. And we will have question and answer sessions after the second presentation is over. Now, please stop sharing.
Dr. Apeksha, please. Yes, please stop sharing your slides. Dr. Apeksha?
Yes, ma'am.
Can you
Yes,
stop
please
sharing?
sharing.
Yes, thank you. Now I invite our second presenter, Dr. Tasneem Bashir, to share her presentation and start the session. Her topic is a call for pediatric clinicians to address environmental health concern in rural settings.
Ma'am, is it visible?
Yes, it's visible. Yeah, you can start.
Good evening to all dignitaries. Myself, Dr. Tasneem Bashir, Junior Resident, Department of Pediatrics, GMC Miraj, and moderator for this session is Dr. Jagdish sir. About the article, title of the article I have chosen is A Call for Pediatric Clinicians to Address the Environmental Health Concerns in Rural Settings. And this has been taken from the journal Pediatric Clinics of North America, which is issued every 2 monthly. And it is freely accessible under CDC's archival repository CDC Stacks, and it is of the volume 72. Regarding the impact factor, it is of 1.9, and in the SDI scoring it is 0.725, and in the site scoring it is 4.3, and in the quartile ranking it comes in Q2. Regarding the author of the article, first author is Rachel Criswell. She is a well-known epidemiologist with institutional affiliations in Dartmouth, Skowhegan Family Medicine and Tufts Universities in United States. And the other co-authors are a multidisciplinary team of pediatric environmental health and public health experts across Dartmouth, University of Vermont, Berkeley, and Harvard affiliated institutions. Why this article was chosen? First of all, we need an equity in the child health because the rural population are always underserved, and the pediatric population in the rural area, and they have less access to the healthcare, and also they are exposed to many of the environmental hazards, and the number of primary pediatric physicians available per capita is very less, and there are still psychosocial stresses such as stigmata, geographical and social isolation in this rural population. So this article mainly stressing over the rural pediatric population and the environmental hazards they are exposed to. Second one, in this article, author is explaining the health effects which are because of these environmental health hazards, and also the author is also explaining the anticipatory guidance to prevent these exposures. Third one, it is an interdisciplinary collaboration between epidemiologists, doctors, and also public health analysts. fourth point, it is a link between environment and child development. And because the children are very active compared to the adult population, and they have a more environmental exposure, and the environmental hazards they are exposed to, and those exposures can lead into effects which can affect their child development. And it is also a bridging a gap in the medical training. Introduction to my article, it analyzes the importance of recognizing and addressing the environmental health risk unique to rural pediatric population, which I will be discussing, and also on the clinicians to actively screen for any environmental exposures or environmental hazards to the rural pediatric population. And if it is anything is positive, it equipped with the tools and resources to mitigate these threats. Objective of the article is, it is addressing the rural pediatric environmental risk and the use of existing tools to support through the mitigation, testing, and medical monitoring. Already what is known on this subject. Children, we are more vulnerable to the environmental exposure, and they are having a very physiologically thin dermal barrier. And we know the metabolism and immune system are mature in children, and they are having a longer lifespan. And when they are getting exposed to these environmental hazards in their childhood, and their effects can come in the later adult life. What this study adds, and in this article, author is describing regarding 3 environmental hazards which the rural pediatric population is exposed to. The 3 which are described are wood stove smoke, well water contaminants, agricultural pollutants including the biosolids and pesticides. And also author is describing the effect of climate change in these exposures, and also describing the prevalence and possible health outcomes because of these continuous exposures in the rural pediatric population. First of all, wood stove smoke. Wood stove smoke, which is emitted from the combustion of incomplete combustion of the firewood. And the most common contaminants present in the wood stove smoke is particulate matter. Particulate matter can be of 2.5 micrometers or less than 2.5 micrometers, and even of 10 micrometers. And when the particle size is less than 2.5 micrometers, there is a high chance that it can reach into the distal alveoli, and it can result in respiratory tract infections. And the other contaminants which are present in the wood stove smoke are black carbon, elemental carbon, organic carbon, potassium, elements, and the other thing mentioned. Effects of this. The particulate matter, which are of less than 2.5 microns in diameter, can result in wheezing and asthma in the child. And also the black carbon, which is the most important component of this particulate matter, can result in wheezing and asthma, cardiovascular risk, and premature mortality. And if the pregnant ladies are exposed to this particulate matter for a long time, it can result in abnormal glycemia in the pregnancy. Even it can result in a small for gestational age infant. And it is considered as one of the most important probable carcinogen. And the things which were described was happened in United States, and the author is in United States, and she had done an article in United States. But even in our Indian population also, we are also exposed to this wood stove smoke. One of the study which was conducted in Bihar, which was conducted in 2016, especially in the Anganwadi population, where initially they were using biomass solid fuels, which is like cow dung cake for wood stoves, for the stoves which are used for cooking food in Anganwadis. And because of that, air pollution has increased, and it resulted in respiratory tract infections in those children who are going to those Anganwadis. So the Bihar government, in association with UNICEF and also Center for Science and Environment, switched this biomass solid fuels to liquefied petroleum gas, which results in less indoor pollution. And these are the trends in the use of solid fuels in households in all over India. And there are states like Chhattisgarh, Jharkhand, where in 2005 to 2006, they were using maximum solid fuels. And in 2015 and 16, also the trend is same and going on. And this is the particulate matter concentration in kitchens all over India. And darker the concentration means that they are having higher concentration of particulate matter in the kitchen. And second one is contaminants in the well water. Contaminants in the well water can be introduced through the multiple sources. First one is the industrial process which produces surface water runoff can seep this surface water into the groundwater and contaminates the wells. And also the nitrates and nitrates which are emitted from the sewages or fertilizers used in the agricultural fields can enter into the groundwater, can contaminate the wells. And also if the chlorination process is incomplete, it can produce disinfection byproducts which are also harmful. And also the industrial waste and pumping lines can leach the contaminants into the household water. These are the common contaminants in the well water, which include nitrates and nitrites, heavy metals, essential metals, fluoride, radium gas, PFAS, volatile organic compounds, pesticides, and microorganisms. Effects of this: the heavy metals such as arsenic, chromium, uranium, radon are considered carcinogens, and the lead nitrates or nitrates which are present in the contaminated well water are considered as probable carcinogens. And if there is much more exposure of uranium, it can result in kidney damage. Even the arsenic, one of the most dreadful thing, heavy metal which are present in the contaminated water, can result in cardiovascular disorders and diabetes. And selenium, which is considered as one of an essential element, can result in hypertension if they are exposed more to. And manganese can affect in the neurodevelopment and growth. And disinfection byproducts, if the chlorination is not done properly, can result in reproductive toxicity. It was the study which was conducted in Assam, and it was found out that 76% of the groundwater samples exceed the WHO safe limits for heavy metals. Mainly it was arsenic. Third one is agriculture exposure. It includes both biosolids and pesticides. Biosolids, which are the final product of the industrial and human waste, which after physical and chemical treatment, which are usually put into lands which are not used, or sometimes it is incinerated. How these biosolids are exposed to the rural pediatric population is, it can seep into the ground and groundwater, it can contaminate the wells. And also consuming the crops, meat or dairy raised on the feed grown in soil fertilized with biosolid also contaminates. Consuming the fish living in the contaminated areas. And there are many sewage processes which removes the dreadful materials from the biosolids. There are certain substances which won't go even after the sewage treatment, which includes the perfluoroalkyl substances, microplastics, pharmaceutical, surfactants, and heavy metals. Regarding the PFAS, it has a long span and can remain in the ecology for about 3 to 8 years. And if it is the rural pediatric population, if they are exposed to PFAS, it can decrease the antibody response to vaccine. It can result in dyslipidemia, low birth weight, and increased kidney and testicular cancers. And the microplastics. Microplastics are which were less than 5,000 micrometers in diameter, and they can colonize in the gastrointestinal tract, liver, kidney, and in the muscles. It can result in oxidative stress, mitochondrial dysfunction, metabolic toxicity, reproductive dysfunction, and also the surfactants, which can cause endocrine and nervous system disorders. And if it is contaminated with hormones and antimicrobial substances, it can cause antimicrobial resistance also. And regarding the pesticides, how the pesticides reaches the rural pediatric population is that it can drift from the treated field to nearby homes or schools where children are there. And also those persons who are working in the farms where the pesticides are used, when they reaches their home, they're taking that exposure along with them. And also the consumption of contaminated water. These pesticides can contaminate the groundwater also. The common pesticides used in agricultural fields by category, most commonly used one is the herbicides, next one is fumigants, then fungicides, and then the insecticides. This is in general the substances present in wood stove, drinking contaminated well water, biosolids, and pesticides. And in the outer circle, it is describing the effects caused by these exposures. One thing to mention, this was the thing happened in Kerala. From 1978 onwards, Kerala was using endosulfan in the cashew fields till 2001 it was continued. And during that time, the first effects were noticed in the animals, and they were having deformed limbs. Followed by it progressed into the humans. It's comprising of hydrocephalus, nervous system defects in the children. So endosulfan use was banned in Kerala after that. And in this article, the author is giving guidance for the clinicians, so that the author is explaining that whenever the rural pediatric population, whenever the pediatrician is having an exposure to the rural pediatric population, they should ask about the exposures, environmental, any exposure they are facing, like such as wood stove smoke or well water contaminants or agricultural exposures as pesticides and biosolids. If anything screened positive, there are testers available, coordinate the state government agencies, and testing has to be done and medical monitoring has to be done. For example, if the pediatrician encountered that the children is exposed to wood stove, make sure the family members that they should burn only the dry wood, remove the ashes regularly, annual chimney cleaning and inspection, install air filter, replace the old stoves with new one. In case of well water contamination, there should be advised that baseline testing has to be done which includes amount of nitrates, fluorides, lead in the well water, and also annual testing for the basal coliform levels. If the tests show high value, remediation should be done, which includes filtration of the water. And if the biosolids, in farm biosolids and farm pesticides, we have to determine the exposure, whether there is any region where the sludges are put on, and if an exposure is found out, we should be testing the near well sources to test for any perfluoroalkyl substance concentration in the well water. And if anything is extreme positive, the alternate water source should be made available for the population. And in case of pesticides, if they are living near a farm that uses pesticides, ask them to close the windows or doors while the pesticides are sprayed in the field. And when they're living with the person who works in those farms, make sure that they remove all their contaminants, all their used shoes and clothes before entering to the home or the vehicle. And also, when they are using water and food contaminated with pesticides, they should be advised how to be used. Implications of these studies, it is incorporating environmental history into routine pediatric care. It also advised regarding the screening tools for rural exposure. And it also strengthened the training in the environmental health for clinicians. And it is a collaborative effort between the public health and community agencies and also the doctors. And it is also ensuring the policies for safe air and water. Strength of the studies, it is a study focused on the underserved rural population. It is highlighting 3 major environmental risks clearly, which I have mentioned. And it is also providing practical, clinical-friendly tools for the anticipatory guidance. And it is a bridge in the gap in the pediatric education. And it also encourages advocacy and policy engagement. Limitations for the study is, it is a narrative, it's not an original research, no quantitative data analysis, it is not region specific, it is entirely in the United States, it is not mentioned whether it happened in a region, specific region, and also there is nothing like intervention. They are advised the anticipatory guidance, and they are also not mentioned whether after the impact of the policy good happened or not. Thank you. Thank you.
Thank you. Thank you. May I request expert Dr. Jagdish Dhekne sir to give his expert comments.
First of all, I want to congratulate Tasneem for a fantastic presentation. I'll tell you why. This is an area in pediatrics, most of the general pediatricians would not be asking environmental histories and history related to, these allergens. And this is very important because very often we find some patients who do not respond to our treatment. For example, you find some of them, have prolonged symptoms, mainly dermatological or sometimes mainly respiratory and sometimes even GIT, gastrointestinal symptoms. I tell you my experience, when I was a resident in Sassoon Hospital from 79 to 83, we had a lot of patients of Indian childhood cirrhosis. I don't know any of you have seen this, but we used to get some patients who would be within 2 to 3 years of age, and they would come with a, jaundice and a firm hepatomegaly, and they would invariably die. And it was a project report taken up by our, beloved Anand Pandit sir in KEM, and we had a lot of people from UK to find out why this is occurring only in Indian population. They finally found out that the vessels that were used for cooking were the culprit. Purvi applied kalay, and that is now gone. And that used to be the cause of Indian childhood cirrhosis. And a lot of copper used to go into the, into the food that were consumed. Once we came to that conclusion, it was almost banned. And we have found that Indian childhood cirrhosis is completely gone after the implementation of this trigger element in food. So this was one important research that I have witnessed myself. And I have last seen the patients of in 85, 86, up to which I have not seen a single patient of Indian childhood cirrhosis. That's why it is called as Indian childhood and cirrhosis. And invariably it would be fatal. And we were doing lung biopsies, and Professor Tanner had come from UK, and then he found out this was the reason. A lot of histopathology studies were done. Now, this was a landmark study which decided, when we realized that there is something a lot in the environment and the food that you give. For example, I'll tell you a few, now what the presenter has said is something related to the Western world. But in our country, there are many other things that should go there. For example, you will find that biomass fuel, म्हणजे आपल्याकडे they use chula and all that, and आपल्याकडे गोवरे असतात ते they burn that. It gives a lot of irritants to the child who stays in that, and very often you will find that the grandmother who is doing cooking out chula, the grandchild is with her. And there is a heavy contamination or ingestion of this very bad irritant inside, and it leads to a lot of respiratory health which is lost. And that's why you'll find there is a lot of pulmonary damage, which produces a lot of diseases, and the lung health is lost. Then the pulmonary function is lost, and it sometimes presents in adults. It is something like we can say something like kidney disease in children, giving you CKDs in adults. So these are infantile origin or childhood origin of adult disease. There are many other pollutions. Remember, this is generally not taken up in pediatrics. And whenever you find a patient is not responding to your conventional treatment, this article emphasizes the need to ask for an environmental history. I will tell you a few simple instances in practice that happen. A family owns a sawmill, and whenever that grandchild or the child goes to the sawmill with the father, he used to get a very bad cough. And nobody would realize he had a complete failure of treatment to, all the inhalers, anti-asthmatic treatment. And the moment the child stopped going to the sawmill, the patient's symptoms were absolutely gone. And that was a trigger factor. Even simple things like school. For example, there is a blackboard, and there is a monitor in the class who wipes the blackboard, and there is a chalk powder which he inhales, and he gets a lot of symptoms once he's a monitor. Once he is not the monitor and is sitting at the back of the class, he does not get symptoms because he is not ingesting this allergen which is so responsible. Please remember, these are the tip of an iceberg. What we detect and what we probably see and test is a tip of an iceberg. There is a lot of things that we probably do not know. Now you can see in most of our pediatric conferences also, there is a lot of emphasis on allergic diseases. Now previously when I used to practice, say about 10 years ago, we would never think of allergic testing. But nowadays when you test and take a good history, you find that many of them have typical allergens which are responsible for the dermatological symptoms, pain in abdomen, vomiting, food allergy. And once you detect a single antigen and give immunotherapy, it is disease modifying. Now please remember, I am not trying to propagate the idea of doing allergy testing, but you take a detailed history. What is important, you take a detailed history. Tell the mother to have a symptom diary. And over a period of few months to few years, she will definitely tell you that this is the cause of the symptom. When I do this, this happens. When you have a strong history like this, you please do an allergy testing specific to those allergens. And when you find it is positive, there is a clinical correlation with this environmental trigger. And if you have some immunotherapy for this, it will be disease modifying for the child. Now remember, disease modifying means the progression and the progression, and it impacts the further impact of the illness in the children. So these are very, very important things. We all see as pediatricians, the disease spectrum has changed a lot. And very often we have overcome a lot of infections that occur because of our vaccines. And that is why these allergic manifestations, environmental issues, as well as the poor response to our conventional treatment. We should think that there is something else that we are missing, and something else we are not treating and targeting is the cause of this problem. So before I end, I would say, Tasneem, you have done a great job. The article is somewhere from, not from our country, but it opens a Pandora box for all of us as clinicians to think that something is not getting well with the child. At least think of allergic disorders or environmental pollution. The next important thing is there are endocrine disrupting chemicals. Now these are a lot in the rural as well as in the urban area. And these are responsible for a lot of hormonal disorders that you see in girls and boys. You can say the menarche has come down quite, precocious puberty has happened. The incidence is increasing. Now this is because of the environmental factors and endocrine disrupting chemicals. So these are very, very important things. some of the studies that are done in our country also should be really studied, because these are country specific, environmental specific, and we should find out what are the main culprits in our own country, in our rural area. So there is India and there is Bharat. Bharat is rural population. Remember, Bharat is far more than the metropolis cities we see. So please remember that in rural areas, this is completely neglected. We should see this, and we should address the population and the doctors in the rural India to think of this environmental, disrupting chemicals and pollutants to overcome all this. And this will definitely improve the health of our children in rural areas. Thank you very much. Congratulations, Tasneem. I
Thank
think
you, sir.
it was a great pleasure to be in the seminar in this. I was very happy to be here with all of you, and I'm very happy that MahaAP has actually, they are promoting, and they're trying to get the new pediatricians in the horizon, known to all of us. So these are great, to budding pediatricians who should be encouraged on this journal to journal group or journey to journal group. That's very good. It's a very good idea of the MahaAP. Thank you so much.
Thank you. Thank you, sir. Thank you so much for your inputs. And now may I request our scientific convener of MahaAP, Dr. Minhas Sheikh, sir, to give his comments. Dr. Minhas?
Yeah, thank you, Chitra madam. Respected senior, dear friends. I'm really overwhelmed today. The reason being, Dr. Vaidehi happens to be my students at GMC Nagpur. And the way she, analyzed and expressed herself, you feel gratified that your own students are doing so good. So thank you, Dr. Vaidehi, at the outset.
You, sir.
So also both the speakers, if you see the way they have presented, the Apeksha and the other presentation, I'm very impressed. The second presentation when she talked about the rating of that article, that's something which is really impressive. How she has seen the first slide was really impressive, and not only that, the way they spoke is phenomenal. I mean, it's a heartwarming to see all those things. Number one. Number two, both the experts have been really on point with regard to their description. And I do agree with Dr. Vaidehi that we need to actually practice the delayed cord clamping. We talk, but the practice has really been, we have to encourage the practice. That's number one. And number two, with regard to the second topic, yes, when we were postgraduate, it was more of, more of infectious disease and all. Now it's a behavioral science and environmental science. Environment is taking a lot of things to come. So excellent pickup from our Mohanty sir. He is the one who picks up these topics. When we see these topics at the outset, ye kya topics hai? But when we discuss, we realize the importance of those topics. So thanks to entire Raigad team, their seniors, their mentors, including our own Mahesh Mohite sir. And over to you, Neha, for this. Thank you.
Yeah.
Thank you,
sir.
Minhas
Thank
Sheikh, sir. Yes, ma'am.
Thank you, sir.
And one addition from my end, I must compliment the MahaAP team, Dr. Pakmode. He has been very clear about all these topics and all. I mean, the type of activity should go on. So he is leading from the front and making ensure that we remain academically oriented, more academically oriented. So we are Indian Academy of Pediatrics. We want to remain Indian Academy of Pediatrics. That's our motto. So thank you, Dr. Pakmode sir, leading the team from the front.
Now I invite Dr. Mahesh Mohite sir to if he wants to add something. Over to you, sir.
No, first of all, it was, congratulations to both presenters and both the experts. It was summed up so well. Actually, these two cases or two kind of studies gave different field coverage, I will say. The cord clamping was related to clinical medicine, and the environmental was related to more of a social or public domain, more of a policymaker's domain rather than something in our hand. We can only think of it, we can only recognize it, but it's very difficult many times to prove it. And you have been talking about the pollution issue for the rural. Well, believe me, we have been reading and watching the news of Delhi every year. The pollution closes Delhi for 2 months in that harvesting period. Every year it has been happening. So many children, so many offices, work from home culture is getting established many times because of that. In those months of somewhere like October, November, somewhere, Delhi absolutely is blackened out. And all the tier one cities in this country are having absolutely very poor, very poor pollution scores. So this is an eye opener. Unfortunately, we can only recognize, we cannot really address to it because it's again a policymaker's kind of domain. How much we can do to that and how much you will get a response. I may be talking about negative, but you can see last 10 years in the capital of India could not change it. With all the policies, even capital of India could not change that situation. And every year is getting more and more worst. As far as the first delayed cord clamping, again, it's a wonderful thing. But perhaps we as a pediatrician, we need to train our gynecologist and obstetrician because again, most of the times it remains in the hands of our obstetrician when to cut the cord. Your role starts only when the baby comes in your hand. I'm sure whether you have been practicing in Wadia and you must be discussing with all obstetricians and sort of training them. But when it comes to private clinical practice, you are invariably called when the baby don't cry, and by the time the baby is out and cord is cut. So nothing is left in your hands. And 23, 24 weeker, yes, we do get them at times. Risks are multifold. This is one thing which you are preventing, but you will agree with me that they have very poor kind of autonomic or auto-regulatory mechanism in the brain. So there are multiple reasons why they develop IEH, and this rapid cord clamping or kind of rapid, or even if it is about 10 seconds kind of cord milking. Vinay, I just want to ask you in the Wadia and of course the presenter, are you practicing that in Wadia? In say, as you get a
So
26
yeah, sir,
weeker,
we
do you
practice
do that?
delayed cord clamping after 28 weeks of gestation, but between 23 to 28, we have not yet started practicing because of the risk of IVH, which was there, which was proven in some of the trials. But yeah, beyond 28 weeks, we definitely try and do delayed cord clamping. But in case if the baby is not vigorous, then we may like consider cut cord clamping in those babies. But yeah, less than 28 weeks, we don't.
Yeah, I mean, delayed cord clamping is an established science, no doubt. In a full term or even in preterm, one would try. But
So
cut cord clamping in a baby who is who is not vigorous, we are going to do a resuscitation because that situation of hypoxia itself is going to create a havoc. And in that, to push that extra blood to that baby who is already unstable. I mean, we need
yeah,
to.
so that is where the rate at which the cord is milked comes to play. So if it is very slowly milked, it has been proven that it doesn't increase the risk of IVH, especially after 28 weeks of gestation. There are some non-inferiority trials also which have been conducted with respect to our cut cord milking and delayed cord clamping, and they have cord milking has not been found to be inferior to delayed cord clamping. Of course, delayed cord clamping should be practiced as and when possible, but if it is not possible, then the second option could be cord milking.
Anyway, overall, it was absolutely wonderful experience today interacting with you. Definitely addition to our knowledge, and we need to sensitize our gynecologist. If not for the extreme preterm, at least the routine term babies, they can try this whenever there's hypoxia. Just
And
cut it
for
this time
cut
and start
cord
doing it.
milking, I think the advantage is that the neonatologist can do it, even
Oh,
if
we can. Oh, yes, you are
even
right.
if the obstetrician refuses to
Agree.
cut the cord late, the neonatologist can still
Agreed,
milk
agreed.
the cord.
But I think
And
this study need to be definitely very
yeah, the number here
aggressively
was
passed
less.
on to
It
the
was
obstetricians.
yeah, here we need more studies definitely because here the numbers were less. It was just a feasibility study. We don't have long-term outcomes, but the short-term outcomes look good.
Excellent.
Yeah,
Thank you very much.
definitely.
Thank you.
May I ask our mentor, Dr. Nimen Mohanty sir, to comment on these articles? Sir?
Good evening, everyone. I'm excited to listen to all of the speakers. So, while selecting these topics, actually, I'll tell you that we have conducted a study here in MGM. I was the guide, and we did milking of the curd for about 200 babies, and 200 babies were delayed cord clapping. We have seen there is no problem of hypervolemia or IVH or symptomatic abnormality in the baby, any of the babies, and there is no also there is no hyperbilirubinemia also noted. That is within 1 week, I am saying. But further we studied them. Every month we did that hemogram, and that normal physiological anemia need not occur in these babies. And normally the babies lose weight about say 10% of their body weight in first 3 days. That surprisingly did not occur in these babies who had this cord clapping. Then we further followed up. The DDST was done for these babies for 1 year. So their development milestones are way ahead of the control babies. And the head circumferences were more than the other babies, but the control babies. So the rate of increase in weight, rate of increase in height, and rate of increase in head circumferences was much better than in the study group than the control baby. So that means the brain growth was occurring more. So there is something which has maybe from the placenta, there is some cells which has been maybe helping this, which need to be studied. These are observation. And also in the preterm babies, we have, as Vaidhi said, we have done only beyond 28 weeks to 35 weeks. So we had no issues of any problem in this. I'll say one thing, that this message should be very, very firmly sent to our gynecologist friend, as Dr. Mohite has pointed out. This is very important. See, we are a society, a scientific body. Individual level, we are working in our best. But insofar as this thing, gynecologists, you see the textbooks of 1950s. I am an old guard, so I have studied from 66 to 70 was my MBBS. Those books recommended delayed cord clapping. Because of the corporate culture, the gynecologists do not have time to wait for the cord to cut the curd or milking the curd. So you depend on the gynecologist, it will never happen. You have to put your best foot forward, and once the baby out, you say, this is my child. So I have to decide about this baby. We have done the milking of the curd. What we do, we do 3 times milking. In the first forward milking for 10 seconds, then the proximal end which is towards the placenta is released. The cord refills from the placenta. You do the second churn. Do the third time. So 3 times it is done, 20 ml per kg, the baby gets benefit. So there is no problem in doing it. But the corporate world is like this, like all this corporate hospital, they get the prescription of a dabba milk at the every birth, they do it. And how do they prevail upon the pediatrician? I don't understand. We have to put our foot down. No, this is my baby. I'll do it what is the best required for this baby. And then to the society also, we should collaborate with the FOXI and for more presentation. And we have hard data with our own data. Like Wadia has own data. We have our own data. We should go very strongly, not hesitantly or in a shy manner. We should like in the society also, IAP also should take up this. And secondly, about the other topic, see the climate change has come. If you remember the old days, we had this starvation days. We have seen. We have got from USA PL 480 those connects we got it, and through that we got this Parthenium. Parthenium is everywhere. We have done a study in PGI Chandigarh. This Parthenium pollen was given to see that asthma cases, their antibody level is very high in these asthma children who are living in these Parthenium areas. This is causing a lot of problem in our country. So this is one example. So many things, environmental pollution is occurring in our rural areas. I come from a very rural area of Odisha. Their cow dung is really burnt, and the fume that the smoke comes out, and this is a normal. Nowadays, this gas is being is going to rural areas also, but still now, cow dung is a common fuel. They burnt it, and the smokers, the household smokers, the incidence of respiratory problem in their children is very, very high. So the sensitization of our own pediatricians is very important. While taking the history, you must ask what is happening to such issues. What USA did in 71, this Bangladesh thing occurred. Kissinger visited India, and then he went to Pakistan. From Pakistan, he was secretly taken to China, and they decided to collaborate. All the USA industry shifted to China because US is worried they do not want any environmental pollution. They let this industries goes to third world countries. Like China and any other country, this came up, and USA was very, very conscious. From those days, they are thinking, and he was futuristic, that we should not suffer from any environmental pollution. Maybe we'll spend more in the importing these things, but will not suffer from pollution. So this is not only a policy direction. These policy makers need to be sensitized. We have to put up a demand as pediatricians also. And this is the reason. And environmental pollution, environmental problems everywhere is there. So government, this Mrs. Narayan Murthy, in one talk in the parliament, she could say that this Gardasil vaccine is included in the immunization program. So this is going to come very fast. These politicians are doing it in their own way. But we should, it's a common problem. The mass people are suffering, and we should sensitize our policy planners also. It is not only that, treat our children, we should also have some social responsibility and act in a manner it is desired. This is the idea of splitting these topics only to sensitize ourselves. Thank you.
Thank you. Thank you. After a long time, I could see Dr. Ramakant Patil, sir, our past MAHA-IAP president, very good academician. Sir, do you want to, in short, tell about your experience with environmental pollutants and the changing scenario of organic and pesticide and everything?
Thank you, ma'am.
Ramakant Patil?
Yes,
yeah.
yes. Am I audible? Yeah.
Yes, sir.
Mohanty, sir. Dekne, sir. Good evening.
Good evening.
Yeah. President, sir. Good evening. Yeah. And Mahesh, sir. Minas, sir. I wanted to say that it should not go as it is an alternative to delayed cord clamping. The cord milking, wherever there is no delayed cord clamping possible, then and then only the cord milking has to be done. Whatever studies are there, sir has done to study on 200 babies, but whatever cord milking has been done, it has been done only once. And here, at least whatever studies I have seen, 2-3 studies, they have done only once. But since your study size is larger, 200 babies, it will hold more water after it gets published, because 3 times milking has been done. And the cord has to be cut more than 30 centimeters. That must have been covered there. So it is, even if it is non-inferior, it should not be projected till on this date, as on this point in time, that it should be, if it is not possible delayed cord clamping, then the cord milking has to be done. And second important point about environment, this thing that in last 30 years, 30 new diseases have been seen of organisms which have come to human this thing illnesses, out of this 75% are from animals, zoonosis. So these zoonotic diseases are very important, and very one health policy is there of WHO, that as we have said in PSM, that was agent, host and environment. Now it is a human, animal and environment. And in rural health, even if low, middle and income countries are less exposed to this, but deforestation, different this thing in contact with wild animals, not the domestic animals, since they are getting displaced, and it is rural area is going to contribute more. So our harping should be there in environment care in rural area, which will prevent zoonotic diseases. And it has been said that which are likely pathogen X, which are not known, and likely prototype pathogen, 30 pathogens which have been detected and which can cause the future epidemics. And most of them, 70-80% chances of this epidemic are likely to arise from the rural areas world over, where there will be more interaction with the wild animals, wild displacement because of all these things, which is going to be in rural area. So it is very relevant, very nice topics. And I think even if it is, as Mahesh sir has said, it is more of a policy decision, and we clinician, how much we can do, but we have definitely in our hand to keep on making them aware. Thank you, sir. Thank you, ma'am, for giving me a chance to express my thoughts.
One
Thank
line
you, sir.
I have
Very
to add.
important point. Yes.
I want to have one line as to the corollary to Dr. Ramagan said.
Yes, sir.
Actually, delay cord clamping is the recommended thing. Why we choose to milk the cord? Because the corporate environment, the gynaecologists are not prepared to wait. They just to cut and vanish. So we'll tell them, in case you do that, so we will do this milking and that will save your time. That we have seen there is no problem in doing that. Thank you.
So
Thank you, sir.
we also have to think in their shoes. And when it is a normal delivery, we definitely can. And when I used to attend the call till 5 years back before COVID time, I had motivated two obstetricians to practice the delayed cord clamping. But whenever there is cesarean section, they have to hold the corner of the uterus, the bleeding chances, and so many things are there. Even some obstetricians have even tried breast crawl also, even in scissor like that. So some people are so good. It is the onus is on us to sensitize them further and further. And in normal deliveries, it is definitely possible. And here in the milking has two studies are there. It is for below 32 weeks also.
Yes.
It's 28 to 32 weeks also there, and it is definitely a non-inferior to the delayed cord clamping, the milking of the cord.
Sir, next time we'll bring the breast crawl. We have conducted a study.
Yes, sir.
Breast crawl. I'll show you something very significant findings.
Yes, sir. Yes, sir.
Thank you so much. Thank you all the experts. Dr. Neha, are you there? Neha, ma'am?
Yes, ma'am.
Yeah. I think it is time for giving vote of thanks. Most of the questions were answered during discussion.
Yes. So today we had two excellent topics discussed, selected by Dr. Neeman Mohanty sir. Wonderful presented by both the speakers, and very good expertise comments from both our experts of today. I would like to thank both the experts for accepting our invitation and being the expert for today's journal journey. And very much thankful to Dr. Neeman Mohanty sir, Dr. Minaj Sheikh sir, Dr. Chitra Kulkarni ma'am for doing all the hard work behind each session of JJ. Right from selections of articles to preparing for each session. I would like to thank our MAHA-IP President, Secretary General, Raigad IP President, Secretary for giving us their support and platform. Would thank the presenters of today, Dr. Apeksha and Tasneem, for preparing and delivering their articles fantastically. And Dr. Ramakant Patil sir and Dr. Srinivasan sir presence and discussion was icing on the cake. Thank you, Pallavi ma'am, for the technical support. And thanks to all the attendees on Zoom as well as YouTube channel for giving us joining us today. So
Neha, one correction. One
Yes, sir.
correction.
Yes.
Hence
Yes,
onward,
sir.
the word Secretary General is reserved for the CIP only. I got so many mails every time. Don't utter the word Secretary General for the state secretaries. He is
Okay,
only
sir.
secretary.
Okay, sir. So we request all the attendees to please join our next general journey on 1st of October, 9 p.m. So thank you all. Good night, sir.
Good night, all of you. Wonderful.
Good night.
Good night.